Good afternoon, everybody. The pharmacy board and everybody else here in the audience. I know this is a very important topic for everybody. I first want to kind of talk about my background, why I'm here, and my experience and who I am. I'm a vascular surgery surgeon in the community. I also am fairly politically active, as some of you know. I ran for the state legislature. As a vascular surgeon, probably about 15 or 20% of my patients have neuropathic pain. Besides for that, vascular surgeons have within the domain the treatment of several pain syndromes, including thoracic outlet syndrome, complex regional pain syndrome, complex regional pain syndrome, and obviously diabetic neuropathy. Since I had so many patients within my practice who are pain patients, I actually am one of the founding members of the Iowa Pain Institute. And that's an institute that's here in Des Moines that was founded by Dr. Pippin as the founding chairman. And what it is it's a group of close to 80 or 90 clinicians who deal with pain patients, and we meet once a month, and it's kind of a journal club. We have, we invite in speakers, but most of the time it's just the members within the group. We present papers and we review the papers, and then we discuss them. And I've been a founding member and been going to it on a monthly basis for, it's now going on, it was 93 that we started, so it's now going on 6 years that it's doing it. I've actually been asked several times to be the chairman, but I have too many other responsibilities, and so didn't take that on. So even though I'm not a pain doctor, I have a lot of experience with pain. As the last speaker said, I hope that you deal with this from a scientific basis and not purely from an anecdotal basis, although I am going to be presenting both some anecdotal and some scientific data to you, because the anecdotes, I think, are important. But from a point of view of should a drug be legal versus it being controlled, there are certain criteria that you need to judge. One of the criteria is obviously addiction potential. Another criteria is abuse potential. Right now, for most of the patients who I treat are being treated with a combination of depressants, antidepressants, and are being treated with narcotic pain medication, both of which have a very high diversion rate in the community. As a matter of fact, each year at the Iowa Pain Institute, we have one of the undercover drug agents from the state, from the FDA, who's based here in Des Moines. He comes and he presents the diversion statistics for the state of Iowa, and it's absolutely staggering. A significant percentage, and I don't know the exact percentage, but a significant percentage of pain medications are diverted, and it's not in the single digits, it's in the multiple digit percentages, are diverted to the streets. And these medications have significant addiction potential and are significantly abused by patients. But let's talk about the patients that I have that are using the medication therapeutically and using it appropriately. I just had a patient in my office an hour and a half ago who, at the age of 14, came down with juvenile onset diabetes. And he's been a severely brittle diabetic. He's now in his 30s. And he's developing severe peripheral, actually he developed about 6 years ago, severe peripheral neuropathy that I'm seeing him for. He basically wants to keep working. He's very upset that he can't, but because of the effects of the antidepressants and the narcotics that he's on, what he's finding is he's not able to concentrate enough to work. Now, he's not one who has ever tried it because he's a very law-abiding citizen. Last week I published an op-ed in the Iowa Bystander, which I'll also, when I submit my written testimony, I'll submit a copy of that with it. And in that op-ed, I because of that op-ed, I ended up getting about 20 emails from people who were medical marijuana users, either legally or illegally. There was one that stands out of my mind particularly, and I'll give you a copy of that email with it. It's an Iowan. His family all lives in Iowa. When medical marijuana became legal in California, he was completely disabled because of his medical condition. When medical marijuana became legal, he went to California and he started using medical marijuana. He got completely off almost all of his medications. He got to the point where he could work productively, and he's now productively employed, almost completely off his medication. And he is, the problem is he can't even come back to visit his family here in Iowa because he can't be off the marijuana and he doesn't want to go back onto the medications. When I treat a patient clinically with pain medications who have neuropathies, and this is specifically neuropathies, it's not other pain medications, because I treat lots of patients with post-operative pain, I treat lots of patients with other types of pain, but specifically neuropathic pain. When I treat them with this, what I tell them is, this pain medication is not going to help with pain. What it's going to do is it's going to basically sedate you enough so that you can tolerate the pain, And so what we're trying to achieve with the antidepressants and with the pain medications and neuropathic pain, which is a very large problem in this the diabetic patient population, and also post-traumatic patients who have complex regional pain syndrome or reflex sympathetic dystrophy. What we're trying to accomplish is just to get them so that they can basically either sleep or rest. But what we do by accomplishing that is we make them non-functional. We make them that they're so sedated from the pain medication that they are totally non-functional. Now and I'm sure a lot of people have given you these statistics, but I just real quickly want to reiterate them. In the United States in 1994 and 1995, and I use those years, you'll see why in that for a specific reason, there were roughly 140,000 people who died from alcohol-related causes. About half were from the direct medical effects of the alcohol, and about half were from traffic fatalities, either as a driver or as a victim. In that same year, there were about 440,000 people who died from tobacco-related diseases. The reason I use that year is because it compares to Great Britain, because there's not good statistics in the United States, but Great Britain keeps very good statistics. In a 2-year period, 1993 to 1994, there were only 5 people they could identify, and Great Britain is 1/4 the size of the United States. So in a 2-year period, only 5 people they could identify that had a marijuana-related death, and all 5 of those were from asphyxiation, from throwing up and choking on your vomit. But still, it's a much, much smaller number. It's from looking at that, it's a much, much safer medication. Now, by the way, I at one time was a fellow, and one of my major professors was with the Food and Drug Administration. So for a 3-year period when I was in, and the rest was at National Institute of Health. For a 3-year period when I was in Washington, I spent 2.5 days a week at the Food and Drug Administration and got very involved in, very knowledgeable about their practices, at least back then. What I learned was that what you need to do is you need to show that the drug is safe and effective. And that's the basis for it. The problem is that it's a drug company who is then proposing this drug, and they are going to be selling the drug. With marijuana, because there's no drug company that is going to be selling it, there's no proponent that goes to the FDA to do this. Because of the 1937 law, it does not fit under the shade, which is the law that our own Senator Harkin passed, that said that the FDA cannot say no to a nutraceutical, to a natural substance, or it would be able to be accomplished under it. It basically is, it's one of the safest, most effective medications that we have for a lot of these conditions. Now, specific